I want to talk about research evidence grading. I'm grateful for the invitation. I'm also grateful for the introduction. The important point to begin is that evidence grading is usually the last step in the process of evidence synthesis. So, keeping that in mind, these are the subheadings that I've chosen for this presentation. I want to give you some orientation. What is research excellence, levels of evidence and grading, and some of my own opinions and conclusion. So I presume all of you have done some basic research training. I'm unsure if you have had the opportunity to link what you have learned with what happens in clinical practice. So I'd like to take you through that first. When a patient presents to us, we have some idea of what their ailment may be due to. This is called etiology or pathogenesis. And then through taking history, performing an examination, and conducting some investigations, we make a diagnosis. And once we have the diagnosis, we can give a therapy which hopes to improve the prognosis, changing the clinical outcome. So this is the thing that researcher wishes to inform through their research projects and publications. Etiologic research, diagnostic research, and therapeutic or prognostic research. And these research needs can be met through primary research, whereby we collect data directly from patients, or systematic reviews where data are collected from published papers. The typical approach to framing clinical question can be put within this context. So, for example, if the question concerning prognosis or therapy is that whether this patient will survive, then we can say that there are two options, an existing treatment or a new alternative. And through a study of a cohort design or a randomized control design, we can determine whether people receiving the new treatment or the standard treatment survive more often. Now, you may have heard that cohort study ranks higher than randomized control trial. And this is an important feature in evidence-based medicine of point number 3. So evidence-based medicine is formulation of clear clinical question on the lines I described just a moment ago, then searching the literature to find the relevant studies, to appraise the study, the first feature of which is the design of the study. And then you got to think about implement useful findings in clinical practice. So when we appraise the design or design related features of the study, another word apart from critical appraisal for this activity can be called assignment of level of evidence. And then when we go on to step 4, which is implementation of useful findings in clinical practice, this we can also call it generation of recommendations for practice. On what I've said so far, is there any question? I'd just like to take a little break to ensure that we are all on the same wavelength before we jump into other aspects or features of my presentation. I look to the coordinator for some guidance. Are there any comment, question, hands raised, or comments made? Please let me know.
No, sir. I think it is clear for now. There are no current questions, I think.
All
And if
right, thank
anyone
you.
does have a question, you can open your mic and ask Dr. Khalid directly as well.
Okay, I'll continue and then take another break when you can ask me questions. So you know that I'm open to seeking your comments and questions as I proceed in my presentation. So think about it this way. Scientific knowledge is created through published articles. The task is that this knowledge should enter the evidence pipeline and ultimately reach the patient. In order for it to reach the patient, the knowledge need to be persuasive. I may read a paper, but if I'm not convinced, I'm not even going to remember what was in the paper just a few minutes after having read it, because other things will take priority in my mind, because if I believe in those other things more than the paper I just read, there is no space in my head available to take this non-persuasive information forward. Then with that persuasive information, I got to make a decision. This decision-making process involves many players. It involves the patient, him or herself, but also other colleagues who work with me in the healthcare setting. If all of us are not persuaded, then really the decision cannot go forward. Once the decision is made, it got to be implemented. And then finally, if it is implemented, then we got to continue with the decision made. So look, the point is knowledge creation alone is not sufficient. Unless the knowledge is presented in a manner that is persuasive, the knowledge is, for practical purposes, useless. It will just stay in a PDF file contained within a journal volume, which will be of no use to anybody in the shop floor of health service, where doctors interact with many other health professionals to make decisions and implement those decisions and continue with the implemented decisions in improving the outcome for patients. So I'll take another break over here and see if now anybody has any questions. Okay, I don't hear anything or any comment. In this case, I'd like to proceed. I'd just like to check if through the system it is possible for colleagues to raise hand or make a comment. Just looking at the Q&A section, it doesn't appear that any Q&A has appeared. Okay, Hamza has indicated that you can type your question here, or you can ask the question by unmuting your microphone. I'm happy to take your question, as I've said before. All right. Okay, so so far we see that the key feature is that undertaking research is not sufficient. Presenting the evidence collated through research and published as a paper in a manner that is convincing to people, including healthcare providers and patients, that is the key to improving healthcare. So grading is the system of assessment of the evidence that allows us to judge whether the recommendations we are making to patients, or we potentially can make to patients, are persuasive. In making these recommendations, we got to consider whether there is a balance between the benefits of treatment versus the side effects or harms of treatment, whether the evidence has quality. Here we, in simple terms, can think about study design and can say randomized trial is better than cohort study or case control study. So perhaps we are more likely to be persuaded by randomized control trial. Then we talk about values and preferences. Well, if the trial is studying cancer and is simply reporting changes in biomarkers, but is giving you no information about mortality, maybe you will value this evidence less, simply because the information concerning biomarker has no preference for the patient. Survival is the thing that is of real preference to the patient. And then there is obviously the issue of cost or resource allocation relevant to the health system. So quality of evidence, which is the item number 2 in this system of grading, can be high quality, moderate quality, low or very low quality. And we'll look at how this assessment can be carried out. Study design, randomized control trial, cohort study, or case control study is one feature of evidence quality assessment. From this and other features collated together in a single assessment, we can then generate strength of recommendation, which can be strong or weak. And then the recommendation can be strong in favor of using an intervention or strong in favor of not using an intervention, or it is weak in favor of using or not using. So let me just at this stage review what I have just said through the next set of slides. What I've explained to you is that purpose of research is to publish papers in journals. Then you can say your professors tell you that you should try to publish in international journals, not just in Pakistani journals, and then those in more advanced levels of academia would say, well, you need to be publishing in high-ranking journals with higher impact factors. But the reality is that research is not just for the sake of getting published. Research is for the sake of benefiting society. So the research output should benefit patients. And how can it benefit patients? This is the journey that grading of evidence takes as we take evidence forward and consider it for decision making, not just for publication. So this journey is called research translation. In this research, the initial steps might be lab research, then there is patient-centered research. From lab, we got to go to health impact. In this journey, there are to's and fro's. One aspect of research may be clinical efficacy, then effectiveness. This is called T2 translation. Then evidence synthesis or meta-analysis. This is called T3 translation. And then guideline making. This is where evidence grading comes in, and this is called T4 translation. Phase 1 trials precede T2 translation, and there is phase 2 and phase 3 trials, and phase 4 trials follow guideline implementation or the process of grading. The phase 2 or clinical efficacy type studies are small pilot studies. Phase 3 are multi-center studies. And then evidence grading enters this translation journey in T4 translation, where we are talking about evidence synthesis, meta-analysis, and evidence grading. So I'd like to take another break here and see if anybody has questions over here.
Sir, there were a few questions in the group regarding evidence reading, but I think you will be covering that in the future slides. They were asking, can you re-explain what you mean by evidence grading?
Is this a question written down in Q&A, or is it, where can I find it? So I'd just like to read the exact wording of the question.
No, it was sent to me by a participant.
Okay, all
They
right.
were
Look,
asking.
I will go through the specific process of how evidence grading has been recommended for use in a moment. So thank you for highlighting that this is of interest to the audience. All right. If, as I see no questions in Q&A, nor I see any hands raised, I'll proceed. Okay. So the basic feature of quality of evidence is inside the study design. As I said before, randomized trial is regarded as better than cohort study, is regarded as better than case control study, regarded as better than case series, and so on. However, once we have a study of good design, our confidence in the finding may be increased or decreased depending on other features. For example, in a randomized trial, we calculate the relative risk. If the relative risk is close to 1, we will not think that the effect associated with a small relative risk is of a large magnitude. In a case control study or cohort study, if a multivariable analysis is used and there are many other confounding variables discovered, then the quality of that evidence will fall down even further. And as I was mentioning earlier, related to outcomes, if we are talking about survival, we are far more likely to be interested in that evidence than an evidence that only talks about a biomarker level. So putting all of this information together into a single table is what is called evidence profiling. Now, before I proceed further, I put this question to you. If the method section of a journal article is replaced with that of another article on a different subject, then how many clinicians reading this mosaic do you think will fail to notice the substitution? I'll appreciate any comments on this question.
I think the majority of the clinicians will judge this mistake.
They will pick this up, Dr. Shiraz.
Yes.
Anybody else who should like to disagree, agree, or say something more? Well, look, I see many names on the screen. Haris Khan, Amina Khan, Maliha Malik. Please feel free to unmute your mic and go ahead and make some comment.
Hi, Dr. Khalid. I don't think they would be able to pick the methodology part because oftentimes the methodology is quite objective. Like clinical trials follow more or less the same methodology, like would it randomization, would it use these statistical methods. So if a clinician is not paying interest very deeply to the methodology part, he might miss that he has actually used this methodology section from another randomized control trial.
Okay, so Mashood, do you think that a doctor, you are one or you will be soon, who has spent 18 years of their life studying with their parents first, then in school, then university, then medical school, then house job, then have done another 7, 8, 9, 10 years specializing, and then after all of these effort, they come across a paper because they have pressure of time and they don't have training in doing research. They will just completely miss the point that the method section does not belong to the thing in which they started reading the title and the abstract. Is that right, Mashood?
Yes, I feel oftentimes the people are more interested in going through the results, like what does the trial say? They don't pay that much attention to the methodology, like how the research was conducted, what were the bases, was this trial registered. They are more interested in going through the table, results part.
Yeah, okay. I'd like other comments on this point. Thank you, Mashood and Shiraz, for your and hopefully encouraging others to come forward with comments.
And hi, Doctor. I second Dr. Mashood Ahmed. I really think the same.
Like Dr. Mashood. Okay, very good.
Yeah.
Okay. Look, I'm going to give you the answer as found in this research study. They found in the United States of America, which has sent people to the moon and brought them back alive, that in their medical wards, presumably of the 50 of you are attending this webinar, many of you have the desire to go to this country and make your careers over there. They found over there in the 80s that 7 out of 8 residents failed to notice that the method section has been removed. What does this mean? Well, I give you my analysis of what this means. Well, I believe what this means is the practicing doctor who's busy seeing hundreds of patients every day has no time. They want a cookbook. They want to be told, do this. And they want to be told also something like, what we are telling you is worthwhile. Take it seriously and do it. How does that sound?
What I understood by your statement is that residents are basically spoon-fed. Like these are the results. Uh, you should be using these in your practice. Like residents are not interested in actually reading the whole length of the paper. They are more interested in seeing what is the abstract saying and how should clinical practice be.
Well, there are 52 of you in this webinar. I believe that you are the exception. The majority of your colleagues have no interest in research. Or if they have, it is superficial. And without any training, if you read a paper, the method section of a paper, I mean, it's not going to make any sense to you. So you're just going to skip that. What is your interest? I mean, your interest is to keep progressing in the ladder of the career and do things that you believe or you have been made to believe by your superiors are good for your patients without making the intellectual effort of trying to understand the evidence. Am I being too harsh?
No, I think you are right. If I'm from personal experience, usually when I'm looking up a disease or a new treatment, So I also end up skimming the results section without looking at methodology. And part of the reason is that I think, I believe that if a paper has been published in a credible journal, it must have gone through a lot of reviewing and editing and elaborating by credible people in the field. And so because of that, that saves us the time. And because certain people have that skill in them, so I can count on their judgment, which is why the paper has been published. Hence, I think most of the times I end up actually just going through, not giving much thought to the methodology section and going to the conclusions and the extract that's given. But this is a new perspective you've given.
See the slide on my screen? Can you see the slide on your screen?
Yes.
You can see that if you rely on New England Journal of Medicine or Journal of American Medical Association or British Medical Journal or the Lancet, you can see that 90 to 80% of what you're going to read in these journals will not be high quality. So I break this myth for you just now that please don't rely on the journals. They will tell you rubbish. They will feed you rubbish, the majority of the papers. How does that sound?
That does come off as a surprise. But my question would be, how have we given them the ratings on the quality? What is our standard then?
It comes to you as a surprise. Let me explain to you why it comes to you surprise. In my opinion, it's because your teachers have told you that these things need to be respected. The British Medical Journal comes out of London. The Lancet comes out of London. The New England Journal of Medicine comes out of New England. What do you think? No one has taught you really to assess the quality of the papers. You are being taught, like I was when I was at your stage, to just accept on face value what appears to be valuable. Is that correct? Without making the effort of trying to understand the content included. Do you agree with that?
Yep.
I'll appreciate more comments on this idea that we are just now discussing.
Hi, Dr. Khalid.
Yeah, please go ahead. Yes, please go ahead.
If this is the case, then how do we differentiate the articles in these journals from those in the other normal journals?
Well, welcome to the course organized by your course organizers who are taking you in that direction. The journey is not straightforward. The task of distinguishing what paper is useful, high quality, valuable to your patients, and the others, the majority which are not, which one is which, is not a straightforward task. And it is made difficult by the fact that even the Gucci and the Armani of the medical publishing field deliver you rubbish clothes the majority of the times. क्या ख्याल है?
Well, obviously that comes as a surprise.
Okay.
So I always believe that these journals
publish. I've given you something that is surprising for you, because welcome to the world of evidence-based medicine. You are about to enter a jungle where you're going to have to find your own direction, and without learning the proper critical appraisal and research skills, it is possible that the Gucci and Armani of medicine will sell you fake stuff. Do you know how many papers in COVID have been found to be false and retracted?
Well, I've heard that a lot of papers were false and they were just rectified and they had
Well,
false evidence and false results
look,
presented.
one of the first papers to be retracted was published in the New England Journal of Medicine. It came from Harvard Medical School. So congratulations on trusting the Gucci and Armani of medicine. I urge you to be extremely careful. COVID is the thing that we faced in last year as a new problem for which we prepared for last 100 years to do the correct research. And every week, approximately 2 papers have been retracted.